Hi, everybody. Good evening. My name is Dr. Kiran Melkote. Welcome to the July webinar of AHRER, which is Association for Harm Reduction, Education and Research. I'll just hand over to Dr. Sree to begin the session formally.
Thank you, Dr. Kiran. I would like to welcome all our viewers to the monthly webinar series hosted by Association for Harm Reduction, Education and Research. This month, we are hosting a very interesting session about the recent leadership change at Ministry of Health and Family Welfare. Before we proceed with the topic, I would like to introduce our panelists. And today we are joined by Mr. Anupam Manur, who is Assistant Professor at Takshashila University, and also by Dr. Ravi Balu, who is pursuing doctoral studies in Public Health and Epidemiology stream at University of Albany, New York. And this particular panel discussion will be moderated by Additional Director of Association for Harm Reduction, Education and Research, Dr. Kiran Melkote. I would just take a couple of minutes to give a formal introduction of our esteemed guests, and I would just read out their backgrounds and their illustrious career for the benefit of the audience. Mr. Anupam Manur, who is currently working as Assistant Professor at Takshashila Institution, an independent center of research and education in public policy, especially situated in Bangalore. He teaches economic reasoning and macroeconomics public policy programs, and he's responsible for designing the curriculum for the educational programs in Takshashila Institution. He's also assistant editor for Indian Public Policy Review, an online and open access journal of economics, politics, and strategy. He obtained his master's in international business economics from Lancaster University and also worked as research associate at Indian Institute of Management, Bangalore. He has wide research interests at the intersection of economics, technology, and public policy. He's currently working on platform economics, India's ongoing job crisis, digital payments, and New World Order. He has published several editorials in Mint, Financial Express, Hindu, NDTV, Scroll, Deccan Herald, Bloomberg Quint, Asia Global Online, and others. Also edited 3 books under Takshashila Institution Press. Welcome, Anupam Manur, for this panel discussion. We are extremely delighted for accepting our invitation.
Thank you so much. Entirely my pleasure.
Now I would like to introduce Dr. Ravi Kumar, who has obtained his Bachelor degree of Medicine and Surgery from Madurai Medical College and completed Doctor of Medicine, Community Medicine at All India Institute of Medical Sciences, New Delhi. And he was the principal investigator for Tobacco Research Network of India, which is funded by Wellcome Trust. And currently he's pursuing doctoral studies in Public Health Epidemiology, University at Albany. And he has experience in teaching and research on various public health issues, both in India and US, together cumulatively for almost 11 years. And we welcome Ravi Kumar Balu also for this panel discussion. And thank you so much for accepting our invitation, Dr. Ravi Kumar.
Thanks, Dr. Sree, and thank you everyone in the panel. It's a pleasure to discuss about my work over here and back in India in tobacco control, and I'm always happy to do.
And now I would like a couple of minutes to introduce the moderator of this particular panel discussion session, and who is also the additional director of our association, Dr. Kiran Melkote. He's currently the associate consultant in the Department of Orthopedics at Fortis Memorial Research Institute, Gurgaon. And he's been very active in our association and takes a very key role in pursuing our mission, which is raising public awareness and sensitization towards harm reduction approaches. And before we proceed with our today's discussion, in the latest developments at the Ministry of Health and Family Welfare, the leadership changes have brought about a lot of interest in the directions the health-related policies might emerge. And today's topic is going to involve a lot of discussion and ideation, co-production of ideas with the engagement of the experts who are joining us today in this panel discussion. And this will be a moderated panel discussion by Dr. Kiran Melkote. And we hope that this discussion will engage the audience who are joining us globally, nationally, and otherwise. And we hope that your insights and your inputs, which are welcome to be posted in the chat box, will be taken up for discussion and interaction towards the conclusive 20 minutes of the time. And without much further ado, I would now like to invite Dr. Kiran Melkote to proceed with the panel discussion of today's topic. Thank you so much for your time.
Thank you, Sree, for those kind words. I don't know when I've blushed so much, but oh, finally your video is back. Excellent. Okay. So I think basically we try to be as informal as possible. If anybody wants to interrupt me, please go ahead. Although I am going to be interrupting. So I think we go into the topic. The topic is basically about the impact on change in leadership at our health ministry. Specifically, how is that going to impact our tobacco policies? The ongoing direction that we have seen in the past few years, whether that is going to change for the better, for the worse, we don't know. So I think before we get into that, I would like to invite Dr. Ravi Kumar to share some background on how the existing situation is, in the sense, what are we talking about when we're talking about the existing tobacco control policy in India, and whether it has any blind spots, gaps, shortcomings. Dr. Balu.
Yeah, thanks, Kiran. So firstly, the situation, it's not only related to tobacco control. If you see, given right from the beginning of 2020, March or April onwards, things have totally shifted towards COVID related. You name any program, it could be staff, it could be technicians, it could be funding or anything. Everything needs to be kind of rerouted or rechanneled. It's not only with India, but globally also. We have seen the same problem here. When I'm also working as a graduate assistant at the New York State Department of Health. That is what I have seen. All the routine work has got impacted. So I think the same thing would have happened for the tobacco control also, beginning of 2020 and then 2021 also, it is going to extend. And I don't know when this will be ending, the prioritization of COVID. And you cannot also let it free, because the impact of it is huge, both economically as well as medically. So tobacco control, in addition to all the other programs that is happening in India, will definitely be having a slight setback, because the focus of the priority of the government is on COVID and how to bring it down. You have issues related to vaccination coverage, you have issues related to the cases, and of course there is lots of discussion going on the third wave, which is going to come. So in my opinion and in my understanding, seeing the global practices, I think the same will happen for India. With all the other programs, tobacco control also will be having a small setback because of the COVID. But once COVID kind of comes to a control, either an increase in vaccination coverage or a decrease in the caseload, definitely things will be going in the in a forward gear. It has to go, because so many things have been left behind. Everything needs to be pulled back and it has to be taken back. But still, my discussion with the other officials within informal discussion, they're trying to catch up with all the programs. It is not that they're leaving it behind, but they're trying to catch up. And in fact, they're doing to an extent, I would say, on the major programs. But once this COVID thing comes to an end, or it kind of stabilizes, definitely there are lots of opportunities to work in tobacco control. And I can also add something more in tobacco control. If you see tobacco control, you cannot do it as a whole tobacco control, because the problem in India is not similar to the other Western world problem. In India, we have both smoked as well as smokeless tobacco. But here in the US or other European countries, it's mostly smoked tobaccos. So whatever policy changes the government is trying to bring, it related relation to cessation or whatever it is, it's pretty straightforward and easy for them to do it. But in India, it is very difficult. Because you have a dual burden. You have a smoked tobacco, and then you also have a smokeless tobacco. So it's kind of, you need to have a balancing act to whatever changes you are going to bring. It's need to be balanced for both. You cannot say that, no, I'm going to only focus on smoking tobacco and leave smoking. You cannot do like that, because equally both are harmful in a different way, though not in the same way, but they're in a different way.
Thank you, Dr. Ravi. I just have a small specific follow-up to that. So, like you said very clearly, that we don't have the same situation in India that may be there in other countries in the West. then how can we follow what they are doing blindly? Can we just apply what works in the West directly to our country situation? Will that, I mean, would you even expect that to work?
In my experience in maternal and childhood and the other programs back in India, like whatever the West does, you cannot blindly use it in India. It is very difficult, like even India, if you see like all the states, each states are unique and different. Like what works in the North will definitely not work in South. What works in South will not work in East or West. So like every program or everything needs to be customized based upon the state's need. And most of the states are trying to do, like the ministry gives a blueprint or a skeleton or something. So what the state needs to do is the state needs to like pitch in and kind of build in based upon their own state requirement. Like some states will be having more issues related to smokeless tobacco. Some states will be having more issues related to the smoking tobacco. Like if you see the CAT survey, you'll be knowing like how the prevalence of this consumption of tobacco product changes state-wise. It is not the same everywhere. Like some states, the consumption is more towards smokeless product compared to smoke. You cannot use the same cessation service that is used for smoke tobacco for smokeless, because that's totally a different dynamics, so you have to see that. So no country can blindly adopt any other country's, intervention.
Yes.
It's not only India.
I'm glad you brought up the GAT survey. So if you're looking at the statistics, approximately 70% of smokers, they actually want to quit. This is from the US CDC. This is not from the GAT survey. So of that, only 10% manage to. Out of 70% who want to quit, only 10% manage to. In India, that number is 4%. Less than that, actually. This is as per the GAT survey. So 4% of smokers who actually want to quit ever manage to. So 96% of smokers are basically being erased by the government, where they don't have any option other than quit or die. So I think that's an important point. Now, I'd like to go on to Mr. Anupam. Do you have anything to add to this about where our current policy falls short, and is there something we can add to that?
Yeah, thanks. I mean, to begin with, I completely agree with what Ravi was saying in terms of that you can't, blindly copy interventions in the West into India. To begin with, I mean, just to give you a statistic right at the start, there's, I think BDs and cigarette contribute to only about 10% of the overall tobacco consumption in the country. Nearly 69% is smokeless tobacco. And this is a countrywide average. You'll have, of course, a lot of disparity within states and so on. So it's very difficult to, just look at, cigarettes as the only culprit in terms of tobacco. So then we go on to the fact that you have a wide array of users of tobacco currently, and there's a whole bunch of public policy issues related to that. So just at the outset, I want to probably say that I'm not an health expert, and neither am I an expert on tobacco, but where I'm coming from is largely from a public policy / economist angle, right? So looking at how all of this works. So the other aspect, and I again, this is a bit of consensus forming, but the other aspect that I agree with is I don't think tobacco control, and this is slightly a pessimistic take, but I don't think tobacco harm reduction or tobacco control will be on top of the agenda for the new health minister, at least for the next few years, because I think the biggest part of I think the priority would be on COVID-related aspect, or how do you prevent the third wave, or if it happens, in which in all probability it might, how do you manage that? How do you mitigate the disastrous effect of that? And then how do you rebuild kind of health capacity in the country? So I think there'll be a lot of things which will take kind of top seat in the beginning, but that's not to say that there's no hope, because there's, to begin with, I think there's also a little bit of comorbidity effects of tobacco use and COVID. So right there, you should, learn to, I mean, I think the government should say that this is an important area to focus on. But going forward,
I'll have to jump in there. Actually, when you're talking about the effects of smoking and COVID, there is a negative association as per most of the studies. It's not a positive association.
Yeah, but I'm quite cynical of that. By the way, I'm quite cynical of who's done the study. What is it for? I mean, I'm quite cynical because all kind of evidence prior to that will tell you that smoking will cause some form of lung problems, and lung problems is deeply associated with something like COVID. So anyway, that's open to debate, but nonetheless, it at least brings to the fore the fact that you got to look at again tobacco use. So probably in a couple of years' time, this might, or 1 year at least, it might come to the fore, and you might want to, the government might want to look at it a lot more deeper. In terms of the current scenario, I think again we take a very blunt approach to policy making in terms of tobacco, and I don't want to go into an entirely historical perspective and so on, but we think that there's only one major kind of instrument that is at the disposal of the government, which is basically taxes, and therefore that is used year on year. Of course, it also is important for government's revenue, which is the second part I'll come to, but that's the only instrument used. The only other thing in minor proportions has been a little bit about public awareness in terms of the anti-tobacco ads, anti-smoking ads that you see, and that horrific image, which we know by now is not really effective, by the way. I mean, it's not enough of a nudge for people to quit smoking. So my main problem is that we're not using nuanced or sophisticated tools that are probably available with the government to kind of reduce the harm that tobacco causes. So that's just my opening kind of take.
Thank you. Sree, you want to add something?
Yeah. Coming to the point you have raised, the opening question asked towards all the panelists, what is the current tobacco policies and where the glaring gaps are? I will speak of my working experience with the low-income group communities, especially migrant population and women and LGBTQ plus communities. That is where we always felt like the existing tobacco control policy and tobacco cessation services are not effectively reaching them, and the coverage is almost non-existential in this group. So we would like to highlight that the current program, if it can saturate the coverage of these services of cessation, especially towards this population, that would be a great improvement to the existing program. That would be my point of input at this point of discussion.
I agree. Okay. So if we had a sort of a wish list, let's say COVID is already settling down. I mean, I would not say it would go away. Let's say it's settling down. Now, the other thing I wanted to add, actually, I just remembered one more point I wanted to make. COVID is a problem, yes, but life still goes on. People still die of tobacco without having died of COVID. Definitely, people can still die of lung cancer. So yes, we may have to put it in the back burner, but that does not mean that we can ignore any sort of a nuanced interventions for tobacco control. But if we try and bring in those 96% of Indian smokers rather, or I would rather say people who smoke or use BDs or use any sort of smokeless tobacco. If you're trying to get their needs, I think there should be some sort of an intervention in terms of harm reduction, in terms of trying to at least save their lives. Whether there is COVID or no COVID, I don't think their lives are any less precious. So we'll move on to the second, we'll just go on to the second question. So if you're actually looking at it, is there anything specific in terms of our tobacco cessation policy right now, which looks at the needs of marginalized communities, low-income groups, maybe some groups like gender marginalized communities like LGBTQs? I'll leave that as an open question. Anybody can answer this.
Okay. Given my...
Sorry. Go on, Dr. Sree.
No, Professor Manur.
So I think we'll hear from Anupam. Yes.
Okay. So I'll come in again from an economist perspective, right? To begin with, again, as I said, I'm going to look at it from the taxes angle. So the way our taxation is structured is that we tax a lot on cigarettes, right? In fact, 84. There's nearly, I think, 68% of the taxes or 70% of the taxes that comes from tobacco is from cigarettes. Very little on other forms of tobacco use. And we know relatively as well that the people who use cigarettes are different from the people who use other forms of tobacco. So what you essentially have is you have some form of what you would call as a tax arbitrage, right? Which is that on the lower end of the scale of tobacco, which is all forms of chewing tobacco, even BDs to some extent, are not taxed properly. A large part of this is outside of the tax net, and so therefore the price of it is extremely low. Which means that people who are, let's say, more sensitive to prices, which are basically people with lower incomes, tend towards using more of these products than cigarettes, right? So you have an arbitrage there, and given that relatively there is a little bit more control in terms of regulation, in terms of nicotine content, in terms of some form of control. Who do you sell it to? Minors, elders, near schools, not near schools. There is at least some form of control when it comes to cigarettes. But all of that just vanishes when you go into rural areas, when you look at other forms of tobacco usage. And so even in our tax policy, we've, again, targeted just cigarettes, not other forms of tobacco. That disproportionately affects people who are poorer, marginalized communities, and so on. So this is just a thought I want to put out there. I mean, I'm not 100% confident when I say this, because I've just, been thinking about how do you use tax policy to try and even the odds, right? How do you make it even so, starting with cigarette length, the tax policy on cigarette length, etc. All of it is kind of, longer cigarettes have higher taxes or something of that sort. So, it's all about arbitrage, right? So people will choose based on that kind of, what is closest to their income choice. So I think that's to begin with, that's doing a disservice.
Sree?
It's extremely poignant observations from economists, which is clearly an eye-opening kind of learning for me. But to match it with my field experience, because of this tax nuances, because of this variation in regulation of these products of low-income group access to this tobacco products, because they are not able to do away with this tobacco use, and because of this price variation, a high-income group person can buy or is in a position to buy that high-income product. So he will restrict his usage to one single tobacco product. But because of this price variation, the low-income group people, because they cannot buy that single high-priced product, they are choosing polysubstances, poly-tobacco product use. For that reason, this low-income group people, because of my recent research experience in this community, I'm seeing that one LGBTQ person is having a tobacco experience of 5 different products. They are having a cigarette, they're having a BD, they are having Keni, Gutka, Panpara, plus other substances also. Whereas a high-income group person is only using a cigarette. So this is something which is not researched adequately. So this taxation is also leading to this kind of poly tobacco substance and multiple substance abuses, because that person, because of his tobacco and nicotine dependence, is unable to restrict only to one product, because he's not able to get that single product because of that particular price parity. So this is something which is not captured, and that is also leading to tobacco use disorders in multiple health consequences. That is my observation, and this is something we need to address in tobacco policies also. When we are thinking the economic perspectives, the health outcomes are also different.
Sree, you're muted.
Yeah, because I completed my
Okay. Yeah. So I was just having a look at a few of the. I was just having a look at a few of the interesting questions. I think we'll get to that in the ending. So I also want to hear from Dr. Ravi. Do you have anything to add on this?
Yes, like you started on cessation and then you started about the marginalized people. Like when Dr. Sree was mentioning about LGBTQ population, like LGBTQ population have been traditionally having issues in relation to accessing any type of service, leave alone the tobacco cessation, but be it your routine healthcare. But things changed after HIV came in. Like they came into the forefront because of the disease and that thing. So like people started noting like, fine, this is a special group of population. The requirements are different. The health issues are different, and more than all these things, accessing the health services, be it a government or a private facilities or a public health facility, has been different and difficult for them. So coming to so overall, when you see that particular community, it has been difficult and different for them right from the beginning. But things have started changing. Lots of clinics have come up. And I shouldn't say thanks to HIV, but it's a blessing in disguise, I would say, like for them. That's all. Like it's not the best way for them to have an opportunity to access the service, but something has led them to come up. For tobacco, like if I'm not wrong, like most of the district health facilities, especially the public, my work has been mostly associated with the government facilities, not with the private institutions. But if I've seen like before I could live in India, like the district hospitals have started introducing brief counseling cessation, like many of the district hospitals. But like the brief counseling and all like has been focusing more towards smoke form of tobacco. But smokeless also need to be considered. Like they ask questions like, do you smoke or do you chew pan and other things? But that needs to be strengthened further. Like we need to see like how these services are happening across the district level. Like someone need to study like like there are lots of organizations, there are lots of NGOs like who are trying to promote cessation services through the health facility so that it is easy for them. Like integrating tobacco control to different programs. Like tuberculosis is one good example because like the pathology is very common. Like in both the cases, lung is being involved. So the TB clinics at the government facilities are one good source where like, or one good place where someone can try to integrate, which I think many of the state governments have started doing it at their level. And even I'm not sure like what is the central government, the ministry's policy toward it, but they have done in many states and it is happening. But we have to see like how effectively it is working. Like when it is working closely with the tuberculosis, since the pathology is same, we can try integrating with many other programs. Like definitely with the mental health program, we can try to integrate it. And similarly, we can also try to integrate it with maternal and child health. Even though like women in India, especially pregnant women, smoking, the prevalence or the incidence would be very low, but other forms of tobacco could be considered among the smokeless forms of tobacco. So these are the few things which comes to my mind when you're talking about cessation, like how we can enhance the cessation service within the country. Like you can start integrating it with many programs within the public health institution. Private institution, I'm not able to say anything much because like it depends upon the objective of the hospitals or the area. Like because like most of the private institutions, if you see like they're multi-speciality centers, right? So they have a specialist cardiothoracic surgeon or they have a specialist neurosurgeon and other thing like tobacco control or cessation may not be their primary because like each center is known for one or two specific specialities. So I'm not able to comment much on how the private facilities could be used in because my experience is nil, I would say.
Thank you, Ravi. Thank you very much. Now, I think we have almost been able to cover the entire state of policy as it is right now. So if I'd also like to ask a brief question to Arun. Hello, Arun. Are you able to hear me? So we have Mr. Arun coming in from AVI. I'd like him to brief us on the vape ban. I mean, we have not been living under a rock for the last 2 years, so we all know about the vape ban. But in the context of the existing policy in India, please go ahead, Arun. Arun? I think we lost him. Yeah. Okay, I think he's not there. Anyway, so moving on to the actual topic right now, which is now we have a new health minister. Will there be a difference? So looking at the working styles of our old health minister and the new health minister, Do you see any specific difference in the way they work? I know it's only been about 10 or 15 days, but nevertheless, do you see any difference in the way they approach the same problems? Now, we have seen how they approach COVID, for example. So, do you see any difference in their working styles?
I have been. You are asking Arin or like?
No, I think I was asking Anupam. Sorry. Yeah.
Sorry.
Yeah. We'll just get to that, but let's answer this question first. So, yeah.
Sorry, do you want me to talk about the difference in working styles of the
Yes,
health minister?
difference in working styles.
I mean, I will immediately say that I don't know enough, it's been too short to make any kind of, I think, conclusions. So how do they approach a problem, etc.? I'm not really sure on that, but I can hazard a guess as to how, again, government policies can shape up with the new minister. And again, I think I'm going to take quite a cynical route there because, well, that's probably a side effect of being an economist. That you always take it. That's why it's called the dismal signs, right? But given again the situation that we're in, that there is COVID, there is a huge fiscal deficit of the government. That there's 6.8% fiscal deficit. It means that they're short of revenue. So all of that tells me that they will look for revenue sources, and cigarettes is a cash cow, or tobacco generally is a cash cow. So I don't see that policy changing any time in the near future. So they will continue to rely on cigarettes, on alcohol, and on fuel. And as we have seen, they've been increasing excise duty on fuel and so on. Last year they didn't raise kind of taxes on cigarettes, but I assume that they might do that in the coming period. So what does that mean? If they're going to start, if they're going to keep relying on the kind of revenue they get from cigarettes, it means that they will not suddenly go for an all-out approach in terms of tobacco harm control. It means that they might not necessarily employ, or at least revisit, the vaping ban, which we can talk about later, because those can potentially harm your revenue collection from cigarettes. So because of that particular reason, I'm again slightly skeptical as to whether they will not do anything that can harm their potential taxes from cigarettes. That's part A. Given also that, again, I don't want to make a controversial statement, but given that they also have a vested interest in ITC, and that it should go on well, I hope, again, it's okay if I take company names, but the fact is that the government through LIC, etc., has a few shares in cigarette companies, and which means that they will not let that go easily. They like that revenue coming in. So all of that tells me that the vaping ban will stay for some time. They're not going to reverse it, unfortunately. So it's on people like us to kind of push for that and say, and push for a public health measure instead of just revenue. That's part A. Part B, again, you cannot look at a minister in isolation. Even if that minister has a different working style, etc., he still belongs to a particular cabinet, and the cabinet works in a particular fashion. And so you look at how, let's say, this government has worked towards certain approaches towards certain aspects. I don't think harm reduction is exactly the way they go. Whether it is on alcohol, again, you don't see a lot of interventions in terms of harm reduction. In fact, different, again, it may be at the state level, but the same party has been doing, or has been advocating for prohibition in certain sense. So that tells me again that bans are the preferred approach instead of harm reduction. The fact that they did the vaping ban itself tells me that harm reduction is not on the top of the priority. They prefer a much more, let's say, a stronger policy approach, which will not work, by the way, but it's more like a sledgehammer kind of approach to problems. Look at the porn ban, for instance, right? Again, that is probably a serious problem. Maybe, I don't know, but the fact that they decide to ban pornographic sites instead of, again, trying to regulate or trying to reduce harm to people that it might cause, it tells me again that is the overall approach towards harm reduction by this government, and that doesn't look very positive, unfortunately. So that's my rather, I think, again, dismal take on this aspect.
Okay. Sree?
I also agree with initial comments, like it is too early to actually follow the working mechanisms of this current new minister, but we can wait and be hopeful that, because any new changes in the ministry level definitely invoke certain hopeful measures and hopeful environment. And I think that is the reason even today's article by esteemed journalist Shantanu Guhare also putting up a kind of, invitation to the minister, submitting a kind of agenda, especially related to tobacco harm reduction strategies, could be an alternative complementary arsenal to the current policies in the country, which could reduce the tobacco harms and reverse the epidemic. So I'm hopeful, because that is how, being a public health professional, we know the pragmatic approach sometimes is to wait and watch and be hopeful, and maybe as Anupam said, wait and watch and see how though one individual style may not be immediately giving us results, the cabinet might consider the global trends, because we are seeing the global trends with the recent United States giving permission for Swedish snus and IQOS, which are considered the reduced risk alternative products, were permitted for United States, and certain global trends are shifting towards more acceptance of reduced risk alternative products. And I hope that shifts will start percolating towards this shores also. And there may be some political changes eventually. And as Anupam just said, we will be pushing forward for such science and evidence-based harm reduction approaches. Just like in HIV and drug harm reduction, we have been persistently backing the science and evidence at the policy corridors, and finally change happened. Similarly, tobacco harm reduction, we will be providing the evidence and science, and ultimately we hope that positive change will also result in tobacco burden countries, especially low and middle income countries, which are having 80% of the tobacco burden, and especially Asia and Far East are housing that 60% burden again of the low and middle income countries. We are especially in need of these harm reduction solutions at policy level, at the population level. And I hope with more persistence from science and evidence, policy changes will eventually happen.
Thank you, Sree. Thank you very much. Now, I don't know if you recall, last month's webinar, we had this same point raised. So there was a very good point made by one of the panelists. The government is not made of evil people trying to rake in money at the expense of everybody else. They are trying to do good, yes. They may be misguided, yes, but they are still trying to do good. They don't get up in the morning thinking, today I'm going to kill these many people. It's not like that. So sometimes, yes, misguided policies, but we have to give them the benefit of doubt. They may not be doing it intentionally. It would be our job to keep on telling them that, this is what your actions have led to. This is what has happened, blah, blah. But I think that's one thing I wanted to add. Dr. Ravi, do you have anything to add to this?
Regarding the question of new ministry and that thing, I left India some 3 years back, so even Dr. Harshavardhan's style, I have very minimal experience and exposure, but still, any new minister, they need some time to work on it and bring in some changes. Definitely there are lots of opportunities. You cannot deny that there is no opportunities or no areas that need some things to be tinkered, but it's just 2 weeks from all the news and what I have seen. So it is too early to judge someone's work or say this has to be done, this should not be done. But given the fact tobacco control has been there for a very long time, the minister or the government officials can start kind of focusing on the areas which specifically I would suggest more towards smokeless tobacco. Every government, or every physician or every organization initially has been working towards smoke form of tobacco, either a BD or a cigarette. But someone starts need to think more in relation to smokeless tobacco also. Like we have to bring in lots of policy changes towards smokeless tobacco products. Like one is like the government was very successful in bringing plain packaging, like which was followed in the Western countries. Like they were very successful in bringing the plain packaging towards smoke form of tobacco, cigarettes. Again, that is one area like where the government can think about doing it, like trying to bring in a plain packaging for the smokeless products also. And the other area which I can see is like try some cessation services for focusing on smokeless tobacco. We have lots of lots of evidences for the smoke form of tobacco, like NRT is already there, and then brief counseling is there. So many things are there. But also we have to see like what is there for smokeless tobacco. Like we have to try to see like how to enhance the cessation for smokeless product also, because like we cannot leave that group, like as Anupam and Sree was saying, like there's a huge population like who are behind smokeless tobacco products. So like we have to bring in the cessation service more into the front relation to smokeless tobacco. That would be my take for the whatever the government, whatever the minister is planning to do in the future once this COVID kind of settles. Definitely, I don't think so. Like things, whatever program that is there, that is going to continue. But if they wanted to do something new, it will take some time.
Thank you, Ravi. And there's one more problem in India. So whenever we have any sort of specific policy by the Union Health Ministry, the states go, health is a state subject. Yeah. So that's where the problem. So if they want to follow, they can follow. But if they don't want to follow, they are welcome to draft their own policy. But that's how it works. So I also have a quick, smaller question. So if you guys had a wish list, now we are talking specifically about, we are speaking specifically about the direction of tobacco control in India. If you guys had a wish list, what would it be? So name just 3 things. We'll start with Anupam.
Okay. One, I think start using some of the revenue that you get from cigarettes for establishing de-addiction controls, de-addiction centers that can help people quit cigarettes. And I mean, I'm one of those people who actually went to NIMANS, went to a de-addiction center and quit smoking after smoking for about 20 odd years, right? So it can help. I'm not using anecdotal data, but across the world, we know that helps, right? Which means then use all forms of nicotine replacement therapy. So it could be patches, it could be gums, and of course it will involve vaping. So which means you need to roll back on the ban on vaping and e-cigarettes. I think that is it can be an extremely important method of harm reduction, all of these, and let people choose. And you need more competition in all of these products. You need more innovation in all of these products. In fact, I would go so far to say that the government can fund some of the innovation in nicotine replacement therapy that can help people quit smoking by using these replacement therapies, right? So and once you have that kind of funding towards it, first you need a positive policy approach to it. Then you need some form of funding for it. Once that happens, I think the market can take over. You'll have a lot of competition in that area, and you will see that there will be innovative kind of products, not just meant for, again, your elite smoker to have for vaping. But I think if you truly let the market work, it can reach into the masses for people who do not have enough money, and it can, act as a viable kind of quitting mechanism for all of these people. So I think that is important. And finally, you need to have slightly better and clever regulations to do with all of this. So as you said, I mean, I don't think they have an intention to do harm, but we also, my favorite saying in public policy is that the road to hell is paved with good intentions. So you can have the best intentions in the world, but if you do policies such as banning e-cigarettes, then you lose control over the entire industry, and therefore you can learn from experiences elsewhere. It's better to regulate better and more clever. So regulate nicotine content. Who do you sell it to? Where do you sell it to? There's a whole bunch of things. What kind of flavors it comes in. You can regulate some of these things. Banning is just not the solution. So those are my probably again quick takes.
Thank you, Ravi.
Oh yes, I would like to stress upon like what Anupam was saying, like de-addiction centers. So far as my knowledge, like NIMHANS is having a robust de-addiction center, and the names New Delhi also has a very good de-addiction center. Then there is in the Central Institute of Psychiatry in Ranchi that also has like promoting de-addiction centers at state level. That means you can start with that. Initially you can start with an enhanced or a robust de-addiction center at the state level, and then the state can take on from there, like how to diversify it more towards the district level kind of a thing. Like you can start from that. Like this can be one of the priority area for the government, like to start a de-addiction center. Like Anupam has given his personal experience how de-addiction center has worked for him, for his well-being. There are so many other stories could be there, like how it has helped a person to either quit smoking or quit chewing tobacco, whatever it is. So like definitely de-addiction center, it works, and it is scientifically proven. Like any countries, if you go, like de-addiction center works a lot. The second area, as I already said, is like plain packaging. That many countries have introduced plain packaging towards cigarette. Like, why not try that for smokeless tobacco products also? Like, rather than bringing in the brand, like just like have a simple white color or a yellow color or something like that. Just a plain cover for whatever the smokeless form of tobacco people are going to use. I mean, there are people who are trying to promote this. I have seen organizations and NGOs kind of trying to promote this, but it's a good start. You know, like even to bring in a plain packaging for cigarette, it took so many years, so much of time. But finally, the government has brought it. You cannot say that the government did not bring it, but it took some time. So many scientific findings, so many evidences were given to the government to let them know, like, okay, fine, this is working, this will definitely work out, this will definitely help to an extent. You cannot say it will 100% help, but it will help to an extent. Like in any of the public health approach, like there is nothing but 100%. Like it's kind of accumulation of multiple approaches. So when this plain packaging is helping in cigarettes, like why not try that in smokeless tobacco? That would be my second thing. And third is like Anupam initially touched about taxation. Like as he was saying, like cigarettes are taxed, like they have a structure, they have a proper tax structure, but smokeless tobacco, like it's a very complicated tax structure. Like nobody knows like how the products are being taxed. Like it depends upon what mixture you're having, what type of contents are there. So like probably a uniform approach to tobacco taxation might increase the price of the smokeless tobacco products, and maybe like definitely increase in the cost, like will definitely prevent people from consuming. Like I wouldn't say they would stop consuming tobacco, but it will reduce the consumption. For any cessation or any abstinence, reduction is the first step. You cannot, like, a cold turkey will not work for everyone. Cold turkey, like I would say cold turkey is good, but a cold turkey method will never work for everyone. They can rebound back again. But beginning with a reduction in consumption of whatever the product may be, a smoke form or a smokeless form, definitely. And like you would have seen, like the GATT survey also says that like the consumption of smokeless tobacco has come down. Same with the smoke form of tobacco across India. Like if you see the latest GATT survey, 2016, like the finding shows like the consumption is coming. It's a good sign. Something is working. We really don't know what exactly it is working. But it's kind of a multifactorial thing which is helping people in some kind of reduction. So these are my takes for what the government is going to begin.
Thank you. Sree, do you have a wish list?
Definitely. Okay. To not touch upon the same points, though I totally agree with all the areas the earlier panelists have said, I would like to add a new list. So if I have my first wish list, it would be like having gender specific, like de-addiction centers everyone is touching upon, but with the rising urban women smoking trends, the de-addiction and cessation services, specially designated for women tobacco users and women tobacco chewers, would be definitely an additional component I would like, because there is so much of social taboo about women tobacco users. So unless we have some kind of de-addiction and tobacco cessation services designated for women clients, they will not be using these services. So we need to think about that angle. And coming to the second point, when policies are being revised or reformed, town hall kind of meetings where priority population groups and consumers can be invited, and their needs, their expectations, if they are reflected in the policy making, that would be a great idea. That would be my second wish. And third thing, India is the second largest producer of tobacco and medicinal grade nicotine. If that can be leveraged for producing nicotine replacement therapy products for utilization of our population, because right now all of us know nicotine gums are expensive, so people cannot buy, everyone cannot buy. So if they can be offered under health insurance schemes for this low income group population, if they are attending a de-addiction center in the government hospitals, under the health insurance schemes, if they are getting subsidized nicotine replacement therapy gums in the government hospitals, that will help them a long way in getting de-addiction services to a complete cycle, not just counseling, not just brief counseling, but along with that, a free prescription for a nicotine gum will help these clients to actually quit the habit. So these are my three wish lists.
Okay. I think we also have one more comment from Anupam. Yes, please go ahead, Anupam.
Yeah, just very quickly. A lot of this will not materialize if the government doesn't really. So if you have the health ministry that has to work along with your basically commerce ministry, agricultural ministry, and labor bureau to make sure that you solve the unemployment problem. So currently, tobacco employs 45 odd million people, and the fact that we need to create jobs, we're losing a lot of jobs year on year, especially after COVID. So at a time like that, they will not again reduce tobacco production when it can also hurt jobs. So in line with all of this, the government also has to think about how does it re-employ these other people, how does it provide a pathway for those people to be employed in other places. And I think crucially, and I'm so glad that Dr. Sree brought this up, that you can reposition the tobacco that you're producing for other purposes. So some of that liquid nicotine can be repurposed towards the nicotine replacement things, and that can be used for exports, which can earn a lot more revenue and raise incomes of the people involved. So there are innovative solutions out there. You just have to look at it, and you have to take a holistic approach to it.
There was a recent report. There was a new report, I think just last week. ITC is doing that. They are making these products for export because they are not allowed in India. So they are actually doing it. So I think that was a very good point raised. And I especially had to agree with Sree. Nothing about us without us. You have to talk to smokers. You have to talk to those who use smokeless tobacco. If you want to make any sort of policies for them, you have to. Otherwise, you're just talking down at them. You're not taking into account why somebody smokes, why somebody keeps smoking. And the fact about taxation is, see, no matter how much you raise the prices, somebody who's dependent on nicotine will find a way to buy it. It's as simple as that.
Yeah.
So I think we have the last about 10 minutes. So I'll hand over to Sree. Sree, do you have any good questions from the YouTube audience?
I'm sorry, I'm unable to see the YouTube. I'm in the Zoom. Whether Arvind.
Okay, don't worry. Let me have a look. Yeah.
Thank you so much.
There are some very very good questions, and I think you guys, Sree, you just take over. I'll just have a look at the question and I'll get back.
Okay. So I would just request Professor Anupam regarding his recent article. I am very much aware that Anupam has written a recent article related to the electronic nicotine delivery systems ban in India. Can you just share your thoughts? Anupam, I know you write very prolifically about a lot of policy issues because you edit the journal. Can you just give us what was the background for this article and how did you arrive at that article, and what is your going forward? What do you think is the implication with this kind of approach?
Right. So thanks. I think largely, if you look at again, you look at government policy and what it tries to achieve. So if we don't ascribe any sort of malice to the policy, then we have to assume good intentions. Then you know that they are trying to help people from tobacco addiction in some way. But unfortunately, the policy option that they've chosen is wrong on many counts, as in it will not give you the kind of desired results that they wanted. Therefore, I thought, that is something that you have to write on and hopefully, at least create some sort of discussion and debate on that particular topic. So we know for a fact that in India, again, as I said, bans of any sort, of any product do not work. From, single-use plastic, that's been banned, but people use it. Of course, again, as I said a couple of times earlier, prohibition in Bihar doesn't work. Prohibition elsewhere doesn't work. So my approach towards all of this was, how do you deal with a topic or deal with let's say a substance which does cause harm to people, but you know that you can't dictate people and guide their behavior in that way, right? Because the government tells you not to smoke or not to vape, it doesn't mean that people will stop doing it. That only lead to an underground market. And I think all of you might be aware of it. I can just walk down to, about less than a kilometer and I can buy any sort of e-cigarettes. I know I can do that, even though it is banned. So, which means that it's not effective. But what is essentially happening are those e-cigarettes are of cheap quality. They're often imported from China. They're often imported from elsewhere. There's no quality control on all of this. All of that means that it actually increases the harm to the people that you're trying to, in fact, help. So, it's a complete, it's a double whammy. I mean, it's shooting yourself in the foot. So, the idea was, how do you prevent that kind of mistake from happening? I mean, it's already done, but can you get out of that? So I just looked at different kind of policy approaches. Tell me when to stop, Kiran.
Okay.
Yeah. You just look at different kind of policy approaches that other countries can take. You look at what US has done in terms of the same thing, e-cigarettes and vaping, and what the UK has done, and you immediately kind of get an idea of which is a better policy approach to take. The US went with an abstinence approach. They first classified it as a drug, in fact. Then they reclassified it as a tobacco product, which still meant that you couldn't, in the US, you couldn't advertise this thing. But in the UK, they did a harm reduction approach, and you immediately see wonderful results in the UK. The number of people who's quit smoking has increased. The number of people who've started vaping has not gone up. You don't get instances of teenagers vaping and so on. Maybe here and there, one or two, but definitely nowhere close to what is happening in the US. So, which ultimately tells you that harm reduction is a far better and superior policy approach towards such a product.
Thank you, Anupam. So I have seen most of the questions, and many of them have already been answered. But I found three of them which are quite interesting. One of them is, should the government legalize and tax all these harm reduction products? So as of now, we have already banned e-cigarettes. The government doesn't have any idea about snus, to be very frank. They don't know also about nicotine pouches, although they are looking into it. So should they actually look into legalizing and starting to tax it? Since you're an economist, I'm asking you, Anupam.
Yeah, the answer is yes. I mean, I think there's no two words about it. Legalize it, regulate it. That's a key missing component. Taxation is still later. That comes later. I mean, that's just in order to, get some money out of it. But the more important public health aspect is regulating it. So, even the nicotine pouch or e-cigarettes, etc., you need to regulate how much nicotine, for example, goes into it. That should not become a highly addictive substance by itself. Then that'll kind of slightly defeat the purpose. It's still safer than cigarettes, but you don't want it to become, addictive to new users, etc. So I think the key is legalize it and regulate it with sophistication, not again sledgehammer approach.
Thank you. So this is a question for Dr. Ravi Kumar. Would an approach which would give some sort of incentives for completing rehabilitation and for proving some sort of a cessation goal or criteria, would that help? Like, for example, in the UK and in a few of the countries, they've already tried it by giving a government job or giving some sort of incentives, money. Would that help in India?
That would be very difficult to incentivize. Like you gave an example of government job, the number of people who smoke and the number of people who consume smokeless tobacco, it's a huge number. Incentivizing like that would be very difficult, but a different approach of incentivization could be taken.
GATT survey says only 4% of people who want to quit manage to quit. So I think we can accommodate 4% in government jobs, can't we?
4%. When you extrapolate 4% in millions and millions, it's a huge number. But the other kinds of incentivization are there. Like, for example, Dr. Sree might be knowing, since she has worked in HIV before, in Tamil Nadu, what they did was, for people who are going to the PPT center to get the ARV medications, they were given free bus passes. They can use the free bus to avail the services wherever the center is there. This is just one example that comes to my mind when we are talking about incentivization. See, everybody wants a job. Nobody will say no to a job, be it government or private. But that is like an economist can answer, like giving a job to million of people just because like, I'm ready to quit. And of course, the intention is good, like you're going to quit. I'm not saying no, but like giving job to million, like it will be too difficult a task for the government to like implement it. But you can think about other types of incentives, like helping them to reach the facilities. One is like providing them a free pass or something like that to go to the government, or providing something like if you feel like that they need some extra like supplements or something like that, which helps them in reducing, which helps them physically and mentally. Like those kind of things could be given rather than like providing a government job.
That was just an example. Maybe something
Okay.
like vocational training or
Definitely.
something. Exactly. So
Definitely.
something like that. Yeah.
Like the Skill India
do
movement is
note
coming
that-
up. Like there are lots of news about the New Skill India movement. Like that could be utilized for them. Like imagine like that could be utilized more towards people who are working in the tobacco farming and tobacco crops and etc. Like they could be given those kind of new skill training. So like helping them to shift from whatever they're doing for the livelihood to a newer skill, which will definitely help. But these are the two things I can think about. Definitely.
Thank you. So I think you also want to add something, Anupam, to this?
Just very quickly, I think any form of monetary or even jobs, etc., that kind of incentives, there's very quickly can go, given the state capacity that India has, very minimal state capacity, it can immediately lead to things like rent seeking, corruption, moral hazard. I mean, you have a whole host of problems, right? A person who never smoked will go up and say, I quit smoking, so give me a job. So, I mean, immediately that's what will happen. If you know India, that you know that's exactly what will happen. So you don't want to do that. In fact, but I want to stress on some other aspect here, which is that for a lot of people who are trying to quit, irrespective of the income stream, societal acceptance and societal recognition of the fact that they've quit goes a long way in incentivizing people. So just a good, I mean, I think that is something that we can look into. Even, I mean, a token which says that I've been sober for 3 years. That's what they do in Alcoholics Anonymous, right? You get a token which says I've been a bronze token for 1 year, something else for 5 years, 10 years, I don't know. But something like that can actually become an excellent motivator. It's a psychological motivator, which is sometimes more powerful than a monetary incentive.
Thank you. I think that's all we have time for today, which we have already crossed the time. Sree, do you want to close?
That was an excellently moderated panel discussion today by our additional director, Dr. Kiran. And I would like to submit my kind gratitude and thanks to both the panelists, Assistant Professor Anupam Manur and Dr. Ravi Kumar. Thank you so much for sharing your valuable time and insights. It has been an excellent learning for me, especially this is the first time we had an economist and public policy editor and such an illustrious panelist with us. And Dr. Ravi has been my friend, and I'm so grateful that he could take time from his doctoral studies and COVID duties in US and join us. Thank you so much, Dr. Ravi. And both the panelists shared their view because both of their diversified thoughts has given us an expansive outlook at how a ministry approaches tobacco policies. It's not just health aspects, the economy, the revenue, the taxation, and in the middle of expected third wave and supposed to be another year of battling with the pandemic, they really placed our perspective. Tobacco might not be the priority for the ministry right now, and it is too early to judge the output or work expectations from the new minister. Thank you so much for alerting us to be more cautious and patient when we are looking at new ministries and ministers work towards tobacco policies. But definitely we can keep on working and keep on gathering evidence and perspectives from our learnings from the field, and having experts like both of you joining us for these kind of meetings where we want to have a platform and unifying platform like this to bring diversified backgrounds and thoughts and voices together. We look forward to host you again, Professor Anupam and Dr. Ravi. Please join us once again when we have time and when we reach out to you. It's been a great session, and I hope our viewers who joined in YouTube live stream today might have gone back with some kind of understanding how policy making happens in India. and it's not an easy job with 1.4 billion and growing population with diversified needs. Thank you so much, Dr. Kiran, for hosting the session on behalf of Association for Harm Reduction, Education and Research. We thank all our well-wishers who joined us today. And we keep doing this monthly webinar series, and we keep hosting a lot of experts. Kindly extend your support to the association. Thank you so much. And that's all for tonight. Thank you once again.
Thank you very much. And if you guys are curious about my wish list, I just want a private island with maybe a private jet and a boat to get there. Small things. Yeah. Okay. Chalo. Thank you very much.
Bye. Good night. Thank you, Professor Anupam. Thank you, Ravi.
Thank you all. Thanks for inviting me. Thank you.